Hey everyone, my name is Sammy Turley and I'm a pelvic floor physical therapist. Sarah invited me to come on tonight to talk to you guys a little bit about what I do and how it can help women after having a baby, or just if they're having issues with their pelvic floor. So, I have been a physical therapist for 9 years. I started off my career in the hospital doing acute care, and then I transitioned to work in a nursing home. I did home health, and then I did a little bit of pediatrics. And then I came to work at the University of Missouri, and I did kind of a mixture of everything, working in the hospital, working at a neuro rehab center, and then doing a little bit of orthopedics at a clinic that offered women's health services. So they asked me if I would like to come on full time as a women's health therapist and offered to get me trained. So I said yes, and little did I know that it would really light my fire and my passion for my career. So I've been a pelvic floor therapist now for about 5 years, and I absolutely love what I do. So I work with mostly women, some men that have issues with their pelvic floor. So tonight I'm going to kind of talk about what your pelvic floor is, what it does, what it looks like when there is dysfunction happening in your pelvic floor, and then kind of how you can find a pelvic floor therapist, what to expect at a pelvic floor therapy appointment, and then I have other things I'm going to address, but it's in my list of questions I'll get to. I can't think of it all off the top of my head. Okay, so the first thing we'll talk about is what is the pelvic floor. So I have a model of a pelvis here. The front bones that you're looking at here are your pubic bones. Your pubic bones, if you don't know, are right here. Okay? And then if I turn this pelvis around, we're looking at the sacrum in the back and then the ilium on each side. So these are pelvic bones on each side that connect with the with the sacrum to make the right and left sacroiliac joints. These joints are where those little dimples in your low back are. So if I point to mine, they're like right here and right here. Okay. So that is what makes up your pelvis. Now everything in red is your pelvic floor. So I'll first identify the structures here. This is the anus, this is the vagina, this is the urethra, and this is the clitoris. Okay, those are kind of our three orifices, and then the clitoris that helps with achieving an orgasm for most women. Everything in red is your pelvic floor. So you have muscles that are close to the opening that are sphincteric, meaning that they open and close your holes. So you have the external anal sphincter here. You have a muscle here that kind of wraps around to the other side called the bulbospongiosus, and it helps to open and close the vagina. These muscles here lead up to the clitoris to help with orgasm. And these muscles here kind of help support the perineum. So your pelvis, this is like a side view of the pelvis. Your perineum is the tissue in between the vagina and the rectum. It's this kind of tissue right here. Prior to having babies, that's pretty lifted up. But then after vaginal deliveries, or sometimes with excessive straining due to bowel movements that are difficult to pass, this area can start to droop. And then we start to notice more issues with organ prolapse and like incontinence and stuff like that. So then if we look inside of the pelvis, you have another set of muscles. Whoa. No worries, I just dropped some muscles off the pelvis. These muscles inside here are called the levator ani. So they run from the pubic bones all the way back to the tailbone. Okay. So they are really supportive. They help kind of hold up our organs, and they also help give stability to our pelvis. So muscles that help support the pelvis are our abdomen, our glutes in the back, outer hips on each side, pelvic floor on the bottom, and then our diaphragm on top. So these muscles really respond to pressure. So when we cough, sneeze, laugh, lift, jump, they tighten. So a lot of times, people that have carried excessive weight in their pelvis or do high impact activities like running, gymnastics, CrossFit, things that require like that bearing down type pressure or just a lot of pounding, end up with really tight levator ani muscles. When these muscles become dysfunctional, it can cause pain. So a lot of times when these muscles get in a spasm or get really tight, they will start to cause low back pain. Some of that can be what we call referred pain, which is just like a referral site or a referral pattern for that pain. But it can also be functional, like these muscles attached to your tailbone. So if they are really tight, they can start to pull on that tailbone and create a distraction force here in your low back. If you're tight on one side of your pelvic floor, it can also start to tug on the sacrum on that side, creating excessive compression in the SI joint or sacroiliac joint on that side. So, in short, I dropped a couple muscles off, but that is what the pelvic floor looks like, and that's what it is. So, my next question I'm going to answer is, what are symptoms of pelvic floor dysfunction? There are a lot of symptoms. I'm going to kind of go over the main ones. First and foremost, everybody kind of knows about incontinence. Incontinence is involuntary leakage of urine, feces, or gas. So if you cough, sneeze, laugh, lift, walk, go from sit to stand, and any of those things spill out without you meaning to, that is incontinence. Sometimes I'll ask women, do you have issues with incontinence? And they'll say no. And I say, okay, so you don't leak with coughing, sneezing, laughing, lifting. And they'll say, oh, yeah, I mean, like just a couple drops, but no, I don't like pee my pants. So even if you're not peeing your pants and like fully emptying your bladder into your underwear, even if it's just a couple of drops, that is considered incontinence. Now, a lot of women have that issue after having children, or some women even have it before having kids. If they have high impact sports or they have issues with constipation, which would put a lot of pressure on the bladder, they can even experience incontinence early on in life. But even if you have just a couple of drops, that is still considered incontinence. Okay, so that's one thing that is a symptom of pelvic floor dysfunction. Another thing might be pain with sex. So some women have pain with initial entry, and what that is, let me get my muscles back. Okay, so oftentimes the pain with initial entry can be from this muscle being overly tight and not allowing something to enter. So this can happen in women who are just built tight. They're kind of born that way. Some women have a history of trauma to their pelvis, whether that be like sexual trauma or a physical trauma, like a blunt injury, maybe a fall or a car accident, or they like hit their pelvis or their vulva on something really hard. Some women just carry tension in their pelvic floor. So some people like hold it in their jaw, some people hold it in their shoulders, and some people hold it in their pelvic floor. And then the other things that can cause that are also childbirth or any kind of like straining or tearing that happens to the vaginal area or the perineum. So painful sex is not normal. If you have it, please find help. It can be so much more comfortable and so much more enjoyable with the right help. Now, a pelvic floor therapist might send you off to a counselor or a therapist of some sort if there is a psychological component to it as well, because they often go hand in hand, especially if there's a history of trauma or anxiety involved in like what is causing your pelvic floor dysfunction. Other symptoms of pelvic floor dysfunction can be lower abdominal pain, pelvic pain, so like pain in the perineal area, pain in the rectum, pain in the vagina, difficulty achieving orgasm. Basically any pain around kind of this area here can be a symptom of pelvic floor dysfunction. We often get women or men, both, who have had low back pain for a long time. They describe it as just like an achy band across their low back. And oftentimes that's those deep levator ani muscles pulling on the tailbone or the sacrum and creating that pain in the low back. We also get people with sacroiliac joint issues. So maybe they've seen a chiropractor and they've seen PT and nobody can quite figure it out. Sometimes the pelvic floor muscles on that side are in a spasm and you haven't really learned how to manage your weight distribution or we call it load transfer in the pelvis. You may be excessively using one side and not using the other side quite as well. Another symptom of pelvic floor dysfunction is constipation. So you should be able to easily just sit down on the toilet and have a bowel movement. There should be no straining involved. What should happen is you sit on the toilet, let's say this is my anal sphincter, relax your pelvic floor, which opens the anal sphincter, and your bowels are contracting and squeezing that poop out your anus. So if your pelvic floor muscles are in spasm and they don't know how to relax and how to open, you're going to have a difficult time having a bowel movement. And you might find yourself on the toilet holding your breath and pushing to get it out, which is not how we're designed to poop. We are designed to squat in the woods to have a bowel movement. Okay, that's just, biologically how we're made. So our knees need to be higher than our hips. So there's something called a squatty potty that gets you in that squatting position to help open the pelvic floor. But you also need to know how to relax those muscles. You also need to have good stool consistency. So if your stool looks like little rabbit turds, that's going to be kind of hard to get out. That usually means that you need more water. If you have like a log, but it's made up of a bunch of little rabbit turds, you probably need more water. What we want is a smooth snake that's soft and easy to pass. If you have a cow pie in the toilet, like you sit down and go and it's literally like a pile of mush in the toilet, you might be somebody that needs a little bit more fiber, or you might be somebody that has an irritated gut. So you may be eating something that's causing your gut to be irritated and not digest that food properly. The biggest triggers for that tend to be dairy, gluten, and sugar. Okay. Let me think what other things cause pelvic or are symptoms of pelvic floor dysfunction. I would say those are the big ones. I had a PowerPoint for this and I just can't figure out how to share my screen / I'm kind of being lazy because it's late tonight. So those are the biggest symptoms of pelvic floor dysfunction. So what can pelvic floor therapy do to treat pelvic floor dysfunction? We can do a lot. Pelvic floor therapists, there are two types. So one type is a physical therapist and one type is a nurse practitioner. Those are the two most common people that treat pelvic floors. So a physical therapist has been through a physical therapy program. Most of us now have a doctorate degree. Most of us, start off in orthopedics or acute care and then slowly work our way into pelvic floor therapy. The nurse practitioner side, they do things a little bit differently. So I'll kind of explain the difference. Physical therapists will look at things from a very biomechanical standpoint initially, and then we kind of look at the other things as later on. But we'll assess the way that you move. We assess, your joint stability, your joint congruency. We'll look at muscular strength, muscular flexibility. We'll look at how your core and your pelvic floor work together. We'll look then also at the pelvic floor and kind of figure out how maybe hip weakness is playing into pelvic floor overtension. Or maybe you have a separation of your abdominal muscles and that's causing your pelvic floor to be overactive. Or maybe that's causing your pelvic floor to drop down. So we use a lot of manual therapy, meaning kind of massage. So if you have really tight muscles in your pelvic floor, which is, I would say, 70% of our patients that we see have really tight muscles at first that need to be relaxed. People need to learn how to relax those muscles, and then we start strengthening them. So we usually use a finger going in through the vaginal canal, and we're pushing in through the vaginal canal to find your pelvic floor muscles. When we find a spot that's tight or tender, we kind of hold pressure just like you would a spot in your neck that was really tight. We hold pressure, we wait for it to relax, and then we lengthen it. So once we get your pelvic floor tension a little bit more normal, we start working on hip strengthening, core strengthening, pelvic floor strengthening if necessary, kind of coordination between all of those muscles to get you to achieve whatever goal you want to achieve. Nurse practitioners tend to use more machines. So they have a tool. It's like a little sensor that they can insert into the vagina that measures muscle activity. It's called a biofeedback unit, but it helps patients watch their muscle activity on the screen. So when they do a Kegel or they do a squeeze of their pelvic floor muscles, they see a little line rise up, and then when they release, it falls back down. They also use a tool called e-stim, or electrical stimulation. There's another probe that they can insert into the vagina, and it stimulates the muscles to contract. It kind of provides an electrical current to the muscles to help them contract. So there are definitely benefits to each type of therapy. The type of therapy with the e-stim and biofeedback is really most helpful for incontinence, not as helpful for pelvic pain or like high tone of the pelvic floor. Physical therapy, honestly, I think we can address all things in a really like well-rounded way. But I definitely have sent people off to nurse practitioners that have no clue how to contract their pelvic floor no matter what cue I give them. And sometimes being able to see it on the monitor or being able to have a unit stimulate the muscles to contract can be really beneficial. Nurse practitioners also have the ability to prescribe medication. So if you do have pelvic pain, sometimes seeing a nurse practitioner for like the medication side of it can be really helpful. So that kind of answers what pelvic floor therapists can do to treat pelvic floor dysfunction. So a question I get asked a lot is, do you see women for pelvic floor therapy during pregnancy? My answer is yes. Do I think that everybody needs a pelvic floor therapy visit during pregnancy? No. I think if you're not having symptoms, you're not having any pain, you're not having leakage, it can be helpful if you don't feel like you know how to push appropriately. It can be helpful to schedule a visit with a therapist just to learn how to open the pelvic floor and get it to kind of dilate and relax so that pushing is more effective. Some people will hold their breath and do what we call a Valsalva maneuver, but they hold their breath and bear down. And a lot of people, when they do that, actually tighten their pelvic floor. So you're not opening it to allow a baby to come through. You're actually tightening it, and then you're fighting your abdominal pressure trying to push something through there when the pelvic floor doesn't know how to open. So that is something that I work with women on during pregnancy. If you are having symptoms in pregnancy of incontinence, pain with sex, low back pain, hip pain, pubic symphysis pain, any pregnancy-related pains, a pelvic floor therapist is a really great person to see. We kind of specialize in these disorders, and so that's probably your best person to go see, along with sometimes chiropractors are really good at treating those things as well. So yes, it's okay in pregnancy. Some pelvic floor therapists will treat internally during pregnancy and some will not. I personally do, as long as it is a healthy pregnancy and you're still allowed to have sex and there are no contraindications. So I kind of ask people questions just to screen things out to make sure that it is safe. I quit doing internal work at 36 weeks of pregnancy because you're full term at that point and I don't want to induce any type of labor. So that is my answer to that. Next question, what is a diastasis recti and when should I worry about it? So it's a pretty hot term right now. A diastasis recti is a separation of the abdominal muscles. So oftentimes when we're pregnant, that baby, that baby fills up our belly and we have two muscles here. One, they're called the rectus abdominis. So they run from our kind of rib cage up here all the way down and they insert onto the pubic bones. If you ever have that black line during pregnancy called the linea nigra, that is what connects the left and the right rectus abdominis muscles. So if we have really big babies that really stretch those muscles apart, that linea alba, they call it linea nigra in pregnancy because it turns dark in pregnancy, but outside of pregnancy, that tissue is called the linea alba. But when those muscles stretch apart, that linea alba stretches with it and it gets thin, okay? So postpartum, some women don't fully recover. Those muscles or that tissue doesn't tighten up enough to pull those muscle bellies back together to where they're almost touching, like they were pre-pregnancy. You have up to a year postpartum to kind of get what you're going to get in terms of recovery from a diastasis recti without intervention. If you do have physical therapy intervention, you can still make progress even 1 year postpartum or further along. Now, it is the best if you start it, at like 6 to 8 weeks postpartum. Your odds of a better recovery are much better. We do not consider it pathological or really like a major problem if it's under 2 fingers wide. Okay, so to measure it, I usually have people lay on their back. I start at their belly button and I just go right above it. I don't stick my fingers in the belly button. So you put your fingers side by side right above the belly button, do a little sit up, and see if any of your fingers fit in a space there. Okay, then I'll go about 2 centimeters above that, do a sit up, check the same thing, and then I go 2 centimeters below the belly button, sit up, and check the same thing. So what you're looking for is width and depth, okay? So 2 fingers wide or greater than 1 knuckle depth is considered pathological or a problem and something that you should try to treat. We also look at, can you maintain pressure, meaning can you keep that linea alba flat as you do a sit-up? If you do a sit-up and you get a dome or a coning in the middle of your stomach, then you do not know how to maintain pressure through that space, and you can make it worse over time. So if you're somebody that's really active, or you're doing sit-ups or planks or yoga, whatever, and you're doming and coning every time, over the years, you're going to start to thin out that tissue and your risk of herniation is going to be higher. So always I recommend doing core rehab postpartum, whether that be something that you know how to do on your own or you go see a pelvic floor therapist to do, but it is really important that you try to rehab your core after having a baby. And there's a lot of programs out there for how to treat and close a diastasis recti. The systems that are most commonly sold, the one that I know the most of off the top of my head is called the MUTU system, M-U-T-U. And I've heard patients have really good success with that. But I think doing pelvic floor therapy is even more beneficial because the therapist will check your pelvic floor and your core function, look at your hips, and kind of just take the whole picture into account. But if you don't have access to one or the time to do that, at least find a system that kind of addresses diastasis recti. Okay, how much peeing my pants is normal after having a baby? I think I kind of talked about this one. Really, none. So give yourself a month, and if you're still having leakage after a month, it's might be normal as far as like a lot of your friends have issues with it, but it's very fixable. So find a pelvic floor therapist and get treatment. Should everybody do Kegels? Why or why not? If you don't know what Kegels are, they are a contraction of the pelvic floor muscles. So this is my bicep. A contraction of my bicep is this. So it's a squeezing or a tightening of the muscle. Usually we cue people to do this by saying, pretend like you're going to hold in gas, or pretend like you're holding in urine, or try to pull my finger up towards your head. You know, if we're working on a patient and our finger is in their vagina. You have 2 sets of pelvic floor muscles. So this set here is called the urogenital triangle. If you want to help treat incontinence, you have to practice using this group of muscles. And the cue that I give for that is try to squeeze the labia together. That's a really hard one for women after delivery. These muscles tend to be really weak and lax. So we work on squeezing those muscles. This set of muscles back here, the back triangle, is called the anorectal triangle. And these are the muscles that you would use if you were trying to keep in gas or to like kind of squeeze around the back side of the vagina. So they're both important in treating a multitude of things. But should everybody be doing Kegels? That's hard to say. I would say if you have not had kids and there's been no trauma to your pelvic floor, not really. So a lot of people are already overly tight in their pelvic floor. The majority of people have too tight of muscles in their pelvic floor. So if you start squeezing and squeezing and squeezing muscles that are already really tight, you're going to make them even tighter. And then that's going to cause more pain and more dysfunction. Some people actually have urinary incontinence or leakage because their muscles are too tight. So if you think about it this way, if my bicep was fully contracted all the time, like if I sat like this at rest, I can't use my arm. My arm is non-functional, right? So if my pelvic floor is always like this, I can't use it. I can't squeeze it any tighter to close my urethra or to close my anus because those muscle fibers are too contracted already. So most of the time, we really have to assess the patient and get a feel of their like resting tension. If it's really good resting tension, they might not even need Kegels. If it's too high, we need to get them to relax first and then start building up Kegel strength if needed. Sometimes we get the muscles to relax and the incontinence and the pain completely goes away. And then I would say a small handful of people have way too stretched out and weak muscles. And in that case, yes, we do start doing Kegels early on. But to just make a blanket statement and say that everybody should be doing Kegels is not a good recommendation. And I think it's really hard to say how many Kegels people should be doing because everybody is different. I have some people that can tolerate 10-second holds for 20 reps, and I have some people that can tolerate 2-second holds for 5 reps without negative consequences. So, see a pelvic floor therapist is really the answer. What should normal bowel and bladder function look like? We talked a little bit about bowels. You should have a bowel movement close to every day. It should be smooth, snake-like, and easy to pass. And then for the bladder, we really would like to see people peeing every 2 to 3 hours. That is about the amount of urine that your bladder can accommodate comfortably and is able to empty completely on a regular basis. So if you're holding it, if you have a job where you hold your bladder for like 6 or 8 hours, you're not helping yourself in the long run. I've seen people that have jobs like that and for years have held their bladder for that long, and they really start to overstretch their bladder and overdistend the muscle fibers of the bladder. Once those muscle fibers get too spread out, their ability to contract to empty the bladder become really poor. It's like a rubber band that's overstretched. Its contractile ability is really poor. So then sometimes you start having a weak stream and difficulty completely emptying the bladder. And then people start to notice recurrent UTIs or feelings of incomplete emptying, or they start dribbling once they stand up. So it is really important that you try to stick to every 2 to 3 hours of kind of potty breaks. I do recommend 80 to 100 ounces of water for most healthy young women. You really need that much water to hydrate your system, keep your bowels moving, and to make your urine really calm and basic, and meaning non-acidic. If you drink a lot of coffee, artificial sweeteners, teas, caffeine type stuff, that is really irritating to the bladder, and it can cause bladder pain, bladder spasms, issues with urgency and frequency. So you really want to try to keep your urine calm. And then when you go pee, I usually tell people, see how long it takes you to go to the bathroom. 8 to 10 seconds if you counted 1 Mississippi, 2 Mississippi, 3 Mississippi. That would be a full bladder if you had 8 to 10 seconds worth of urine when you sit down to pee. If you have 30 seconds worth of urine, you held your bladder for way too long. If you had 2 seconds worth of urine, your bladder was not full yet. So, yeah, hopefully that's some helpful information on that. What does a pelvic floor evaluation consist of? I think I already said this in the beginning, but we look at you musculoskeletally first. So me personally, I will kind of poke around on your backside. I'll look at your alignment of your hips and your pelvis, and then I'll have somebody bend forward and I kind of look at their spine. It's really surprising how many people have scoliosis or just have postural changes, especially after having kids, because you're kind of always like holding a kid and leaning to the side. And so I kind of talk about posture and how that may impact the pelvic floor. Then I have them stand up and lean backwards, bend side to side, and just kind of see what hurts and how much range of motion that they have in their spine. Then I have people stand on one leg. What I look for there is, does their pelvis stay level or does it drop down when they stand on one leg? And that tells me if their hips and their core are stabilizing their pelvis well. Then I'll have them lay on the mat. I look at hip flexibility, sciatic nerve tension, I look at hip range of motion because really tight or really lax hips can cause issues in the pelvic floor. I check for the diastasis recti, the separation of the abdominal muscles. I look at any scar tissue in the abdomen because that can always cause pelvic floor issues and just abdominal pain issues. I'll look at C-section scar mobility. I usually grab the bladder and move it around. I see if it can move left and right and up and down. And then I have them lay on their side and I check their hip strength of their outer hips, roll on their tummy. I check the strength of their glutes because all of these things matter. If you're weak in your external support muscles, your internal support, that pelvic floor is going to be overactive because it's overdoing the job that those big powerhouse outer muscles are not doing. Then I have them change after I explain what I'm going to do with the pelvic floor evaluation, and I will poke on each of the pelvic floor muscles through that vaginal canal to get a sense of how tight they are and how tender they are. I always say they should be soft and swishy and non-painful. If I find a spot that's tight or tender, then that's a problem area. Then I ask them to squeeze around my finger. I want to see how strong their Kegel is. If it's perfect strength, it should close around my finger and pull up towards their head. After they let go of the Kegel, it should fall back to neutral. And then I have them bear down, and I want to see, does the pelvic floor have the ability to move down and open up, and then do their organs spit out of their vagina and kind of mush down, or do they stay in place? They'll move some, but I'm really looking for organ prolapse. You know, do your organs stay in place, or is there enough laxity that they really move downward? And then I treat what I find, and we kind of talk about the plan for therapy, and I give them stuff to work on at home for that first week. So that's what a pelvic floor evaluation consists of. The last question I wrote down to answer is, what do I need to see a pelvic floor therapist and how do I find one? So you need a prescription, in the state of Missouri at least, you need a prescription from a doctor, a nurse practitioner, a physician assistant, or a chiropractor. We can take them from a dentist as well, but I think a dentist referring for pelvic floor therapy is a little weird. Probably wouldn't look right. So if you have any relationships with any of the above, you can typically just email them and say, you know, I think I'm having pelvic floor issues. Can I see a therapist? Now, if it's something where you're worried that it might be like cancer or an STD or a UTI or something like that, go get screened by your doctor first. But if it's something like diastasis recti or sacroiliac joint pain or something like that, most of the time the doctor will be okay to write you a prescription and fax it over to us. How do you find a pelvic floor therapist? There are multiple websites. The ones that are the most helpful, I think, are pelvicguru.com. Has kind of a database of pelvic floor therapists. And then another one is pelvicrehab.org, I believe is what it is. The end of it, I think, is .org. But both of those websites are search engines for pelvic floor therapists. I live in Columbia, Missouri, and here we've got several pelvic floor therapists with the University of Missouri Healthcare in Columbia and in a couple of the surrounding areas. I know there are some in Springfield, and I think we have one in Moberly, maybe one in Sedalia. But there's lots of therapists around. They come and go and sometimes change, but those websites are good places to go to see if you can find one. So I hope this was helpful. I think every woman postpartum should get a pelvic floor evaluation, whether or not you're having issues. I see people 3 years later that didn't have issues until 3 years later that really could have been prevented had they seen somebody at 6 weeks postpartum. So I really encourage you to reach out, ask for help. And we even do telehealth. A lot of pelvic floor therapists, since the coronavirus, have learned how to do telehealth. So it's not obviously as effective as being in person, but if you live in a rural area and don't have access to one in person, that can be really helpful. So please drop any questions you have below, and thanks so much for watching. And hopefully you guys go see a pelvic floor therapist. It really is life-changing. All right, thanks.